Good morning, good afternoon, or good evening, wherever you are. This is a warm welcome for this first combined webinar between the American Society for Transplantation and Cellular Therapy and the European Society for Blood and Marrow Transplantation. So we're dealing with a hot topic, which is strategies to prevent and handle outbreak of COVID-19 on transplant or hematological wards. So this meeting, this will be presented. Next slide. It's a great pleasure to share this session together with Pavan Reddy. He's a professor for medicine in the University of Michigan. So he's the current president of the American Society for Transplantation and Cellular Therapy. My name is Nikolaus Kröger. I'm director of the Department for Stem Cell Transplantation at the University Hospital in Hamburg, and I'm the current president of EBMT. So we were quite happy to have at least five distinguished speakers who are experienced and were actually in hotspots of COVID-19. So first we have Professor Dr. Huang. He is from the Bone Marrow Transplantation Center in Zhejiang University in Hangzhou, China. And then we have also Dr. Rafael de la Cámara. He is hematologist consultant. He's working at the Universitario de la Princesa in Madrid, in Spain, also a hotspot of the COVID-19 pandemic. And we will have last from Europe, Professor Per Ljungman, from the University in Stockholm, in Karolinska Institute. And he will give us later a presentation about the EBMT survey. And Pavan, will you continue?
Thank you, Dr. Kröger. This is Pavan Reddy from the University of Michigan. Welcome to everyone again. And it's such a pleasure to introduce some of our speakers for this webinar from the United States. We have Dr. Zenia Papanicolaou, who is a member of the Infectious Disease Service from Memorial Sloan Kettering in New York, which has been a hotspot for COVID-19 in the United States. And Dr. Stephen Pergam, who is from the Cancer Center, who is the medical director for Dr. Kröger. Could you introduce our next speaker, Dr. Huang, who's going to talk about a personal experience on managing COVID-19 outbreak in a hotspot region from China. And we'll have discussions and recommendations to prevent an outbreak on transplant wards according to personal experience. Dr. Kröger.
Thanks. So Dr. Huang is really one of the most experienced physicians regarding COVID-19. He was actually in the hotspot in Huang. And please, Dr. Huang, we're looking forward for your presentation.
Okay, thank you. Thank you very much, Professor Kröger. And I have the chance and talk about the recommendation to avoid the COVID-19 outbreak on the hematologic stem cell transplantation ward. How about we can set the strategy pre and peri and post transplantation? As we all know, the COVID-19 is a global pandemic disease with a rapidly increased number of the cases in many countries. Unfortunately, today data shows the confirmed diagnosis near the 2 million cases, and the deaths near the 125,000 cases. And in China, I think we also have such the pain experience and the COVID-19 spread. Please next. Next, please. So in our hospital, please up to the last slide. Last, no, next, the last. Yeah, go on. Last slide. Yeah, that's good. So our hospital is the first ever hospital, Zhejiang University School of Medicine, all located in Hangzhou, near Shanghai. So under the February, we will suffer from the COVID-19. And in our province, we have the total about the 1,267 cases. Our hospital has this medical center focus on the treated ulcers COVID-19. We have the total more than the 100 cases, and including about the 42% is the severe case, and the 32% is the critical case. So after the last month, and we have the finished treatment of the Zhejiang province, and I lead emerging medical team and fly to the Wuhan. We all know the pandemic center is Wuhan. So China, the whole nationwide and the medical staff, and are there in the Wuhan to support the Wuhan to fight against the COVID-19. So with the left picture is all the public handbook of the COVID-19 prevention and the treatment. And the right picture is all the worked in the Wuhan hospital. We were treated the coronavirus. Please next. So we all know because the transplantation is also a very important technology to treat the hematological malignancies. So we think during such the spring the pandemic COVID-19, and first we think is the optimization of the screen and the administration is process is very important. In our hospital, we have the fever clinic, and first such the fever patients first go to the fever clinic as the differential diagnosis, and we will use the RNA diagnosis, PCR diagnosis, and also we use the chest CT scan, and also the IgG/IgM test. So if the patient diagnoses the COVID-19, and we will send to the special campus. Next, please. So if the patients should receive the human-body stem cell transplantation, and we will manage of the COVID-19 outbreak. And first, we'd like to evaluate the patient. The area is the high community prevalence area or the low community prevalence area. If the high community prevalence area and the general patients, we will differ plan the transplantation. But if the patient is urgent transplantation, or we have selected the patients, and we will screen and first the differential COVID-19, and we use the RT-PCR or genomic sequence, or the series antibody IgG/IgM or the chest CT scan. And if the patient's differential diagnosis, not the COVID-19, the infection, and we will continue use the transplantation. Please. Next. Yeah. So peri-hemolytic stem cell transplantation. So with the unrelated donor and the related donor are the autologous stem cell transplantation. For the unrelated donors, because it's the many areas we were affected by the COVID-19. So we were shipping and cryopreserving the donor's stem cell with the local laboratory before the condition regimen. So we will should avoid the risk of the travel stop and another high-risk elements. For the another, we'd like to backup the alternative haploidentical donor as a backup. I think it is more safe. And we will correct it and cryopreserve the autologous stem cell and in the liquid nitrogen. And for the related donors, and we maybe we will have the alternative haploidentical donors as the backup, or the corrected and cryopreservation and the donor stem cells for this condition. For the autologous stem cell transplantation, such patients we recommended use the GCSF or the plus the placebo based mobilization, not use the chemotherapy. Please next. So the post-transplantation, we will, I think, is very important to educate patients and our family members on the introduction regarding the isolation and the preventative measures, and the self-isolation and home, and minimize the number of the family members to visit, and the telemedicine visit or the online visit with the doctor, and avoid the go to the hospital outpatient. Maybe we will reduce the risk of the infection. And we also explore ways for patients to have the blood test away from the busy area in the hospital. So I think it is both protected of the patient. Next, please. So we will take such measures, and although we have this suffer from the pandemic of the COVID-19 in a hospital, and over the past 3 months, we total have the 49 patients received the transplantation, including the 39 from the HLA haplotype-related donor, 4 from the sibling donor, and 1 from the matched unrelated donor, and 5 is autologous stem cell transplantation. And however, from the January 24 to the middle of the March, all Chinese cities have to face the risk of the explosive. So have the very planned human body stem cell, and only continue to perform they have for the patients who are already in the laminar airflow clean floors. So until now, all the patients no have infected with the COVID-19. So next. So as next, I'd like to talk about the strategy to handle outbreak of the COVID-19 on transplanted world. Next. Prevalence of the COVID-19 in persons with the hematological disorder. In fact, and our hospital, there is no reported such the patients infected by the COVID-19. But in Wuhan, we all know the Wuhan is the pandemic center of the China. There are the total 29 cases of persons with the hematological disorders with the COVID-19 in Wuhan city. We can see here the pediatric acute lymphocytic leukemia and aplastic anemia and the chronic myelogenous leukemia and MDS and the acute leukemia. I think is the most percentage of such the patients. In such the data, so we was in place published in the leukemia publication maybe the next week. There's the data is shows in low communities prevalence areas only 1 case is COVID-19 in the chronic lymphocytic leukemia, another area of China. So the case the fatalities later is persons with the hematological disease. In fact, COVID-19 since is higher and then another patient. So I think it is a very important conclusion. So how to treat the hematopoietic cells transplantation recipients infected with the COVID-19? We think it is very important. And first is the screen of the coronavirus, the COVID-19. And we are in China according to all the consensus and the we will guideline recommended by the Health Commission of the China, and we will diagnosis use the combined with the RT-PCR or genomic sequencing, and also now we will use the detection of the serial antibody just like IgG/IgM, and also we will combine the chest CT scan. Very important is the confirmed diagnosis depend on the sequence and the IgG/IgM. So if the patient is positive and be removed from the laminar airflow clean room and should be go to the special room for the COVID-19 patient. And if the negative, we should also the differential diagnosis and another virus infection, just like the CMV, EBV, another virus infection. Please, next. So here is the picture is our hospital. We have the special campus for the COVID-19 patients, and 1 building for the staff, and another building for the confirmed diagnosis, and the last building for the special for the ICU for the critical conditions patients. Campus is special for the COVID-19 patient treatment, not in the or the general campaign campus and the mix with another patients. I think it is very important that the isolation such the patient. Please next. So diagnosis and clinical classification. And the golden standard is positive results for the nucleic acid of the coronavirus and from the upper respiratory specimen. And for the suspected cases, and we should adapt it as chest CT scan. And serological methods for the immunoglobulin IgG and the immunoglobulin IgM is important because it's with use RT-PCR detect the virus, just about the 50% patients is positive. But such the negative patients, if we will use the serological methods, I think that such the patients and about the 80% patients is positive. So I think the combined with the RT-PCR and the IgG, IgM detecting is very important. Next. And so all the has the depending according to the clinical medical classification, and we will have the such mild and the modality and the severe and the clinical condition. And we will focus on the severe and the critical condition patients, and the need is such as the ventilators or the another supporters, and maybe you move the ICU unit. I think it is very important such as this patient. Please next. If all the patients, and first we will use the antiviral treatment. Although we have not the proof, and the randomized clinical trial can be the proof is which medicine is very effective. But for our patients, we will basically, which means that we will use lopinavir and then letonavir, and combined some abidovir. And another we will have some just like the treatment and maybe as such the antivirus treatment about the 2 weeks. Next. Yeah. For such the patients and especially for the hematological malignant disease is reported, and maybe the dysfunction of the coagulation is the higher the risk is than the another patients. And there is a report indicated that COVID-19 patients with the dysfunction of the coagulation. 4% of the patients experience reactive thrombocytosis and disseminated and the intravascular coagulations and across the ischemia and the separator infection. So there is the particular concern that the hematopoietic patients with the COVID-19 may have the high risk of the dysfunction. Should be the differentiation of the SOS and the HEMA. Please. So for the patient discharge standard and follow up, and in China, and we have observed some patients also have the negative of the PCR, but they were the very long time, and maybe the IgG positive, IgM positive, or maybe the return positive with the PCR. So for the patients, and first we have the 2 times of the PCR, the virus negative, and they also we have such as oxygen is more than the 93%, and we have another organs is normal, and we will such the patients leave the hospital. We will suggest the patients is home staying isolation 2 weeks, and we will follow the detect the virus and the IgG, IgM for the patients. And after such as a check and the follow up, we will visit the 10 point 1 week, 2 weeks, and 4 weeks after the discharge. And also we will like to monitoring the nucleic acid detection and the screen qualified the donor and the correspondence present. Next. So here is all the hospital have the handbook for the COVID-19, and this handbook has been translated into over 10 languages for free share. And here is all the we were cooperated with the Alibaba companies, Jack Ma, and we will have the foundation and supported. We have such the publish this handbook, and I think we can check this handbook from the website. Next. Oh, thank you very much.
Thank you, Dr. Huang. It will keep moving. Our next speaker is Dr. Rafael Della Cámara, who is a hematologist from the Department of Hematology at University de la Princesa from Madrid. And as many of you know, Spain's been a hot spot. And Dr. Della Cámara, please take it away. Thank you for doing this.
Hello, everyone. First, I would like to thank the organizers for inviting us to let me to share our stressful experience with COVID in Madrid. The next slide, please. I have divided what was our experience at the national level, hospital level, and the hematology unit. And the situation in Spain began in the 31 of January. We had our first case. It took 3 weeks to have a third case. So we were quite happy thinking that we will have a few cases, but the reality was different. And on the 14th of March, the government decreed the alarm status. That means the confinement of all the people at home. At that day, we have nearly 6,000 cases with 156 deaths. On 13th of April, we have nearly 170,000 cases with more than 70,000 deaths. You can see the increase of the number of cases, and this was very, very high. The mortality rate was 10.3%. And we are the second country in the number of cases in the world, and the third country with numbers of deaths. So one peculiar aspect of the infection in Spain was the high rate of infected healthcare workers. We have more than 26,000 infected workers. The peak incidence was on the 31st of March. In Spain was 177, but it reached more than 339. For comparison, you see here the peak of the influenza of this season is 271. And also on 13th of March, there was a national control of distribution of COVID therapies that include Caletra, tocilizumab, sarilumab, chloroquine, and interferon. Next slide, please. So this is the situation at the hospital. It was in Madrid. Our hospital have a maximum of 550 beds, but usually we have only 450 patients in single rooms. But the COVID experience was a tsunami. We have more than 100% beds occupied by COVID patients. Here you have in the peak of incidence of the outbreak, we have more than 100% of the rooms, so between 140 to 490. Now we have 65, all the hospitals are COVID patients, so this imposes a change in everything in the hospital. We have to change all the logistics and organizations. The rooms, many have to convert it to double rooms. Also, we need to increase the number of intensive care units beds from 20 to more than 45. Also, the activities has to change. No urgent surgery was suspended, and the outpatient visit canceled, delayed, or done by telemedicine. Also, the physicians from all the specialties were reallocated to attend the COVID patients in the normal floors, also in the emergency room. And the worst part of the situation was we have a shortage of personal protective equipment. So that imposed a change in the nursing work and also in the medical visit pass. And the consequence was we have a very high rate of health workers infected. 20% of all the personnel at the hospital, more than 2,200 people, were infected. Also, we have a shortage of diagnostics, the swabs, the PCR reagents, so it was difficult to perform all the tests we want to do. Also, we have shortage of medication, particularly with tocilizumab, and also the access to remdesivir was very difficult, so very few patients received it in this period of time. Next, here you see the shortage of equipment in the left photo. You can see what is no homologate equipment. Of course, this is plastic bags joined to make this suite, and on the right you have normal homologate equipment. We have in the last week. Until the last week, we have to use things worse than that you can see in the slide. So this was a really, really bad situation, not only in my hospital, but in many hospitals in Madrid. And the next one, please. So the situation in the hematology department, we have our first case in the 12th of March. Now we have 26 patients. We have divided in 12 stem cell transplant patients, 9 allogeneic and 3 autologous, and 14 non-transplant patients. The mortality rate was quite different, as you can see, was quite low, I would say, in the allogeneic and the transplant patients, only one case, and in the non-transplant patient was quite high, 36%. Nearly 50% of our nurses getting infection. That is very high, so you can imagine how difficult it is to organize the work with 50% of the nurses at home. More than 50% of our beds in the unit was occupied by COVID patients. And at the beginning, we decided to send the infected patients out of the hematology ward. We think that it was a good idea, but after a few days, we realized that this was not a good idea at all, and we have to take back all our patients to our unit. It was absolutely impossible to treat a patient with GVHD in other wards, so we have to take back our patients. The transplant program was suspended. It was absolutely impossible to perform any transplant. We have to disconnect it. We decided to disconnect the HEPA rooms, and also we decided to open windows and ventilate the normal rooms, as that is quite abnormal for us because we have all the windows sealed. So we break the seals and we ventilate the rooms once per shift. And we divided the ward into COVID negative and COVID positive areas. What we have seen was that the clinic of this COVID picture we see in Spain was, I think, quite different from what was described in China. This was underlined in the last update of the European CDC. And we saw two things. First, that the incidence of vascular events was very high. In our 26 patients, we have 2 cerebral strokes. Both patients died. We decided to put on prophylactic heparin all the patients at the hospital and also when they are discharged. And also we appreciate a distinct pattern of worsening in the transplant patients, getting worse in the 3rd or 4th weeks compared to the 2nd week in the rest of the patients. That was, I think, a new finding, but we would like to know if other units see the same, but it's quite repeated. You have the patients in the first 2 weeks are doing quite well, but in the 3rd or the 4th week, the patients get worse. And the next, this is the answer to the second question. What is the recommendation to you to prevent this outbreak? Next slide, please. So the first is that you might think that a situation like that we have in Madrid will not happen in your unit. It is logical. I thought exactly the same when I saw the situation in North Italy weeks before. But I think you should be prepared for the worst and develop plans in advance for this situation. So there was going to appear a publication with the EBMT recommendation that have policies about how to handle the staff, the patients, the transplant candidates and donors. I will not take time reviewing this issue. So the important question is who should be delayed and who should be transplanted. So depending on the situation, the whole transplant program might be temporarily suspended as we have to done. And at the hospital level, you should anticipate a shortage of personal protective equipment, diagnostic tests, and personnel. And to develop plans in advance for these problems is a good idea. You have to plan how to double at least the number of intensive care unit beds. Be prepared for telemedicine for the outpatient visits. And also you have to need a plan for how to test in and how to handle the positive cases. The most important question is when and how these healthcare have to come back to work. And next slide. Yes. So the hematology unit, I think is a good idea to divide it in two areas, if possible, COVID negative and COVID positive, and use dedicated personnel to these two areas. But in practice, with 50% of the nurses sick, it's quite difficult to perform. Also, the ventilation issues are important. You have to decide how to use HEPA rooms and how to ventilate normal rooms. And an important point is that every patient in the ward should be tested before entering the ward on the transplant unit. And also, all the patients that give a negative result should be retested weekly during the stay at the hospital. And what happened? And if you're going to perform, of course, you must have your stem cells at the hospital before starting the conditioning, and be aware of possible clinical difference compared to the Chinese experience. A high incidence of vascular events, both venous and arterial. That is a general experience of many hospitals in Madrid. And also what we see is a delayed pattern of worsening in those patients that are immunocompromised. So that implies a prolonged the follow-up for these patients. And the next. And also you have to need a protocol how to manage these patients. Focus on these 3 points. The antiviral treatment, you have to decide when and how to treat these patients. Also, you have to diagnose and manage the cytokine storm. It's necessary to monitorize the inflammatory parameters, and you need a plan how to use different drugs like tocilizumab, anacura, corticosteroids, and others. And also, other important, very important thing is that prophylaxis of thrombosis. The dead dimer should be monitored, and we have seen extremely high levels of dimer not seen in any other type of patients in the order of 100,000. That is incredible, a number that is incredible. So we recommend to use prophylaxis with heparin in all cases if not have a formal contraindication. And I think this was my last slide. Thank you for attention.
Thank you. We'll keep moving on. We'll discuss experience from New York, from Memorial Sloan Kettering. Our next speaker is Dr. Zenia Papanicolaou, who is member of the Infectious Disease Service at Memorial Sloan Kettering. Again, New York's been a hot spot for COVID-19. And Zenia, if you could tell us about your experience. Thank you.
Thank you. Good evening and good morning and good afternoon from New York City. It's been a very tough month for us. However, we are now having cautious optimism for New York City, at least, as you can see. As of April 12th, our cases are decreasing. The number of hospitalizations are also increasing, and the number of intubations are increasing. And while the number of deaths remains quite high, it has been stable, and deaths are always lagging behind. And these numbers are only for New York City, that do not involve the greater New York metropolitan area. At Sloan Kettering, next slide, we are a self-alone, standing, dedicated cancer center, so we do not have an open emergency room. We treat only our own patients. So while we had been prepared for the worst, we have not reached capacity, and over the last week or so, we have in the hospital about 100 COVID patients, of which 30% require some kind of intensive care unit. And as I said, this has not reached capacity, and while we had been worried and concerned about lack of protective equipment, we have never reached that point. So what we have been doing is actually having dedicated floors and dedicated teams for COVID patients. Hematologic COVID patients are in single rooms. I will briefly say our experience with patients with transplant and cellular therapy. over the last month. We had 32 such patients. 60% were allogeneic transplants, 30% autologous transplant, and a very small number, 6% CAR T cells recipients. And the follow-up is very short, only a mean of 16 days of follow-up. So these cases, some of them are still evolving. The good news is that 50% of the patients were treated as outpatients. Only 45% of these patients were hospitalized. Next. I will give you some breakdown of the hospitalized patients. We had 9 allogeneic and 5 autologous transplants. The infection happened quite a long time after transplant, 23.7 months for allogeneic and 18 months after transplant for the autologous patients. And of note, 30% of the allogeneic transplants came with relapsed, they had relapsed leukemia. And of those with relapsed leukemia, 3 required mechanical ventilation and 3 of those, all 3 died. However, from the autologous patients, only 1 has required mechanical ventilation. Now, 4% of the patients were found to be positive while they had been in the hospital for days or weeks, and this is considered a nosocomial transmission. We do not know if some of these patients got COVID from visitors, because this happened before our visitor policy had changed, or from our staff. We actually have, from the staff that has been tested for COVID, we have tested about 3,000 staff, 30% have tested positive. So in the whole Memorial Sloan Kettering staff community, we have more than 900 people that have COVID. Next slide. Now moving very briefly to prevent COVID outbreak. Our efforts have focused to prevent nosocomial transmission. We had from the beginning dedicated units for COVID patients and dedicated teams, which consist of doctors, nurse practitioners, nurses, pharmacists. All these teams that cares for COVID patients does not care for non-COVID patients. And the number of providers rounding on COVID patients is limited, so it is the COVID doctor for the day, and consultants are using mostly telemedicine and communicating with the primary doctors. We do not see the patients unless it's critical. We have implemented protective equipment for staff, and everybody at all times in the hospital has to wear a mask, whether they are caring or not caring for patients. We are having a screening tool for staff before reporting to work for every shift, and we have implemented no visitors policy. Also, we want to identify COVID cases early. We have COVID testing before any admission or before any procedure, including interventional radiology, endoscopy, or other procedures. Patients that have clinics, they are contacted by phone the day before the clinic, and they are screened for symptoms. If they screen positive for any symptom, they are directed to special areas of the hospital where they are escorted and tested. Recently, we implemented a 72-hour survey and testing for COVID, this is for COVID negative patients. That means that for every patient that is admitted to the hospital with a negative COVID test, every 72 hours they are again tested to make sure they remain negative. We have reduced patient volume, as also mentioned by previous speakers. We have deferred non-essential transplants and non-urgent transplants and non-urgent CAR T cell therapy. And we defer non-essential outpatient visits. Also, we have had 1 patient that was planned for transplant, and because of having the routine COVID test within 72 hours of admission, that patient was detected to be positive, symptomatic, and the transplant was delayed. We are still in a pause mode, stay home stop the spread, save lives. It remains to be seen what happens when some of these measures are lifted. And I'll stop here and thank you.
Okay, thanks, Zenia. I'm Steve Pergam from Fred Hutch, and I'll be going through some of the infection prevention plans that we put together in Seattle. Next slide. Just quick disclosure slides. Next slide. So I'm just going to describe some basic principles of infection prevention in transplant and immunotherapy, describe some of our screening protocols, and then challenges and concerns. And a lot of this will feel repetitive, but I think I want to focus on these things that are important. So most of us have basic policies for respiratory viral prevention that are already always in place to prevent outbreaks. So we have baseline policies on arriving to clinic, masking and testing symptomatic patients. Some centers organize masking during flu season. And then flu vaccine, we train staff to avoid coming to work sick. We have strong policies to assure compliance, and then we train our patients and family for respiratory virus prevention. Next slide. And this slide was to show you sort of the outbreak itself in Washington State. And you can tell from that, hopefully, that yellow arrow is when we started preparing ourselves for COVID coming into our system. Next slide. First, I think it's really important from an infection prevention standpoint is to develop the incident command structure. Next slide. And we really focus on in this discussion is really both inpatient and outpatient modifications in terms of how we practice. So for our isolation guidelines, we focused on droplet and contact precautions for patients with active symptoms and for patients with documented COVID-19, unless they're airborne procedures following the WHO and other recommendations. We've done aggressive environmental cleaning on units to assure emphasized high-touch cleaning. We actually have a wiper that walks around to the entire units that's wiping on a regular basis to make sure that we can decrease fomites. There's masking of all symptomatic patients. Sick staff never allowed on any units or in research areas. And then we've done extensive weekly review of PPE and testing supplies to make sure we have adequate numbers. Next slide. We've really shifted our positive pressure rooms and cohorted similar to what others have done. So it's really been difficult to change from positive pressure rooms. So what we've done is we've added negative pressure machines to particular inpatient rooms to create more negative pressure spaces for treatment. Patients go to COVID-specific units, and so our low-risk patients typically go to these units, and those that are more challenging have been the BMT patients. We've wanted to have excess space on BMT units to be able to manage them. And at the moment, we haven't needed this because of the low number of patients that we've had that have had cancer and transplant have been in our units. But we have a planned cancer, transplant, and immunotherapy COVID-specific unit if needed, so we can manage them there. Next slide. So we really think it's important to do universal symptom screening throughout the entire process. So we screen at our front door and at entry to all facilities, both in the inpatient units and outpatient clinic. We mask all symptomatic patients at the door, and we turn away others with symptoms that are not necessary to be there. There's early triage of patients with severe symptoms who can get immediate care for acute shortness of breath or hypoxia. We do caregiver screening, and we limit those who come into the clinic and inpatient units. We really do face-to-face screening for all employees entering our clinics. And despite all of our warnings, we still have some clinicians that try to come into our facilities with symptoms. So that's really important. Clinical care shifts that we've seen. Obviously, we've shifted elected and non-urgent cases for immunotherapy and transplant to later time points. We've delayed survivorship, a yearly follow-up and other routine visits to avoid them coming to campus. Only essential staff are allowed in clinical areas as well as inpatient rooms. We've really limited the number to see individual patients as possible. We've retrained staff to take on dual or alternate roles so they can help in other areas. And we've organized telehealth as much as possible to avoid people coming into clinic. Next slide. We've really amplified our testing options. So we do testing on arrival to center, testing all transplant patients within 72 hours of induction therapy. We do on-the-spot testing for patients at the entrance with clinical symptoms. We have off-site walk-up and drive-up testing stations outside of clinical areas to avoid patients coming into these areas. And then we do pre-clinic phone calls to assure symptomatic patients are delayed or tested at drive-up windows. And then we have a home testing kit that we think will be coming in the next week or two that will provide additional benefits. Next slide. We've also done admission. We're now doing admission COVID-19 patient testing on all inpatient services, if no testing within 72 hours, and that includes asymptomatics. We do pre-procedure COVID-19 testing with interventional radiology, endoscopy, and other potential high-risk procedures. We do weekly testing on our transplant and immunotherapy clinics because of that prior issue with pre-procedure COVID-19 testing, that our transplant patients get so many procedures that it made it easier to do it through that mechanism, and that's starting this week. And then we do weekly testing of patients in our on-campus housing because of a major risk of outbreaks. Next, we mask all staff entering buildings with surgical masks to prevent asymptomatic, pre-symptomatic transmission and for PPE conservation. We've had enhanced use of hard plastic face shields, which we typically didn't use. We limited VRE and MRSA screening to avoid the need for additional PPE because of our concerns of overuse. Similar to others, we've restricted visitors, family, and we've had no children under 12 years of age in any unit. We've really enhanced education for patients, caregiver, and staff. And then I think a really key piece is consistent messaging. We've had town halls and ongoing what I would call transparent updates to everyone about what is going on through our system and to keep them online for new changes. Next slide. We've shifted to cloth masks for outpatients for patients themselves and for family members to help limit transmission as well, and because of our limits in PPE. Next slide. So there's a lot of challenges, and I highlight the supply chain here because, as everyone knows, masks, swabs, swab equipment, even pipette tips have been restricted in different ways. And so I think it's really key to focus on that. Caregivers continue to be challenging because they need to be in rooms with BMT patients, but how to manage one that might be symptomatic is very difficult. So having patients, if possible, identify a second caregiver that can help is critical. Guidelines change routinely, almost daily, so we have to make sure that we keep people updated about those timeframes. And then lack of testing has been an issue at many centers. We were lucky to have a really robust PCR ability very early in the process, and I think that's been critical for managing our situation locally. And then contact tracing with the number of positive patients in the communities and amongst clinical services, that becomes a really difficult process with limited staff. Next slide. I think that's my last slide. But most important, I think I would just remind people to share your ideas and best practices through the system because that has been very critical for us, including our colleagues internationally and colleagues in China. So thank you.
Thank you again, and we'll keep moving. Our next speaker is Dr. Ljungman. He will tell us about COVID-19 data in the EBMT registry, which has already collected some valuable information to this COVID-19 patients in the transplant setting. Pierre, could you take over?
Yes, thank you very much. And next slide, please. Okay, so that's me. Next, yeah. So when the COVID outbreak happened in Italy first and then in Spain, we realized in the infectious diseases working party that we needed to collect information as quickly as possible, and we decided to use our EBMT registry system for this. So it was initiated already on February 28th. We have 3 steps in the data collection: a registration form as soon as possible after diagnosis, an interim data form after about 2 weeks, and then a follow-up form after the end of the episode. And this is done in collaboration with the Spanish group we did also with the swine flu outbreak. Next, please. So as of yesterday, we have 130 patients registered, 98 allos, 29 autos, 1 CAR T, and 2 we are chasing information about what type of transplant. As you see, it's really spread out over Europe. Not surprising that Spain and Italy have the largest number of cases, but we have identified transplants in several European countries. The age of allo patients, median 54, auto median 59, and 14 out of the 54 allo patients are children. There's no pediatric autologous transplant patients with COVID. Next, please. The median time from transplant in the allo patients is 10 months, from basically close to transplant and out to 20 years after, and the autologous even a broader spread with the median at 13 months out to 403 months. Next, please. Important is that the symptoms at the time of diagnosis, and this is the spread. So you can look at it, say 5% of the patients had no symptoms, so they were screened. 38% upper respiratory, 36% lower, and then 19% had other symptoms, mainly fever alone, but also some other symptoms that have been reported in this pandemic. Next. So similar to what Zenia showed, we have limited and preliminary data with a short follow-up. So I've concentrated this follow-up on the interim form, and then that we should receive approximately 2 weeks after registration. And we have follow-up on 55 of the 130 patients, 44 allos and this is the outcome. So the mortality in the allo patients is 23%, in the auto 9%. It's difficult to see what this really means at this time. We had some early deaths, and so it is possible that we get earlier reports and complete reports on the dead patients than the patients that are still alive and being followed. And the only way to find that out is that the data has to mature. But this is the snapshot of the situation as of yesterday. Next. The cause of death was reported being due to COVID in 9 patients, but 2 patients died of something else. I don't know yet what. And the median time to death from diagnosis was 10 days, 1 out of 26 in the allo patients. And we had only 1 auto patient who died, and that patient died after 5 days. So this is the conclusions, and it's a very preliminary data set so far. 130 patients, 6% with low respiratory tract disease, and the mortality at approximately 2 weeks on diagnosis was 23%. But we certainly need more follow-up data. Thank you.
Okay, so thanks very much all the speakers for their excellent presentation. So we still have time for some questions. So maybe Isabel, maybe we can see all the speakers on the screen. Maybe I can start with the first question from one of our attendings, to Dr. de la Cámara. The question is for Dr. Cámara. You observed a low morbidity in patients who received stem cell transplantation. Do you think this is related to the pure immune response and to a lower RRDS development in these patients?
Yeah, yes, I think that what we are seeing is a delay in the worsening of the patient. So as Per has talked, we have the photo at 2 weeks after the diagnosis. That is, I think, is enough to capture the majority of deaths in the no immunocompromised patients. But what we are seeing is that these patients do pretty well the 2 first weeks. We were quite happy when we have our first allo transplant infected with the coronavirus. And we see that the course was quite mild. But what we are seeing now is after 3 or 4 weeks, these patients are getting worse and some of them get a very bad pneumonia. So I will be very prudent to the final mortality of the allo transplants, because I think this the immunocompromised response maybe is delaying the bad pneumonia we see in the rest of the patients. What is more clear probably is the low mortality in the auto. We have no deaths in the auto. We have 5 auto patients. We have not seen any deaths, and also the experience in the court of the EBMT is like that. So I think that our auto have a low mortality, and allo we need a longer follow-up to know what is the real issue.
I think we have 1 more minute for questions. If there is none, then maybe I can have one quick question or comment from Zenia and Stephen. The notion that transplant patients have higher disease manifestations and perhaps higher mortality appears to be the case from Pierre's presentation so far from the registry data. But could you both comment on, I think the Spanish data suggests there may be as high mortality in heme malignancy patients. Are the transplant patients, instinctively would be at a higher risk, but do you have any data on solid tumors or heme malignancy patients, and how does that compare with the transplant patient outcomes from the limited data sets and obviously limited personal experiences? Zenia and Stephen, if you could just comment on that quickly.
I can comment quickly since we've had more cases. So recently I reviewed 75 of our patients that were treated with hydroxychloroquine during the month of March. And so it's not a complete number of our cases. So I focused most on the patients that died. So of these 75 patients, about one third were discharged from the hospital, 1/3 are still in the hospital, so we don't know what's happening, and 1/3 died. And among the patients that died, which were mostly with solid tumors, well, all I can say is that these patients had come with extremely bad cancer, stage 4 metastatic lung cancers, many with lung cancer on immunotherapy. So you could only see that they were very, very advanced, either by age or by stage of cancer, or with comorbidities, severe COPD, severe renal failure, and so on. The couple of patients that you could see from the chart that had excellent prognosis were patients with CLL. So this is a very limited sample and probably incomplete, but I would say that some patients with leukemia have done badly. I cannot give the numbers. Certainly our 3 deaths that we had in the allo transplant, they were relapsed leukemia after transplant, and these patients get very fast need mechanical ventilation and require also a lot of pressures. So that's my experience, which is very immature.
And Pavan, I would sort of echo the comments. We've had a lot more solid tumor malignancies that have been positive. We've had very few hematologic malignancies in comparison. And what we've seen is that it's comorbidities. So it's related to how severe the underlying disease is. So people that are older, so over the age of 70 and 80, and those who have complicated issues beyond their underlying disease are the ones that are getting into major complications. So it's really a combination of sort of comorbidities and age are the ones that are typically more complicated than others. And we've had some that have been put onto hospice that were positive, that have not developed COVID-like symptoms, but were positive on testing. And our mortality rates have been around 20% amongst the solid tumor patients. But again, it's much more linked to, as Zenia said, high risk, metastatic disease, elderly, and patients with significant comorbidities.
Yeah, Thanks a lot for all the speakers. Unfortunately, we're running out of time, and we have to close the session, even if we have still a lot of questions. So on behalf of both societies and behalf of Pavan, I would like to thank all the speakers for their excellent presentations, all the attendees for getting up very early or still are awake, and hope we can see you another seminar, which we will do together with the American Society for Stem Cell Transplantation and Cellular Therapy. So thanks for joining us, and stay safe. Bye-bye and bye-bye.